Hello everyone, coming to you this morning from Howard's garage. It's a beautiful day. I don't mind being outside, and it's very loud in my house. I have a rescue kitty who's singing love songs at a very high decibel all over the place in there. So I'm out here to try to keep things quiet. You may hear a little traffic noise in the background, but what can I say? I live by a road. We're going to talk today about Chapter 8 in Drug Society and Human Behavior, and that involves the medications that are prescribed to people who have mental disorders. You might want to ask, why do we need to know about that? Because we're going to be substance abuse counselors and not doctors or psychiatrists or whatever that prescribe these type of medications. And that's true, but there are several issues that involve our patients that we need to be aware of this stuff, because many of our clients are going to be dual diagnosed. Dual diagnosis is where you have a mental or emotional diagnosis combined, and sometimes physical diagnoses. They're combined with substance use disorders, for our purposes, of course. And it's a good idea for me to know the signs and symptoms of these mental illnesses and what they may indicate for referral purposes, and also what they may indicate for treatment purposes. Not that I'm diagnosing or primarily treating a mental disorder or emotional disorder, but I am going to have patients who have that type of disorder along with their substance use disorder. Consequently, I need to know something about how those symptoms will probably inform what I'm going to do in terms of doing assessment and creating a treatment plan, and also about referring people who have these symptoms who may not have been diagnosed before and who may have been self-medicating with alcohol and other drugs. So it becomes somewhat important. And without wasting any more time on introductory stuff, let me get over here and I'll share my screen with you, and we will go right into the meat and potatoes of this. There you have it. Medications for mental disorders. Begs the question, what are mental disorders? And that's a very good question. A mental disorder in America constitutes a lot of things. And they're legion, as a matter of fact. We operate here in this country from the medical model for the most part. And generally, per the medical model, a mental illness is conditions that manifest basically with a set of symptoms. And as you noticed before, probably when we're looking at our DSM-5, these diagnostic criteria is what they're called, as if you have this, this, and thus for this long, and there's no presence of this other, then you have this. And that's kind of the way it works. It's kind of like a mix and match situation with symptomologies. Symptoms may appear as features of a number of different illnesses. You don't have to be schizophrenic to have psychotic episodes, and you don't have to be bipolar to have manic episodes. It's how these symptoms appear, and if they appear in clusters and in the presence of other things, etc. And that's how you make a determination of what disease the client's suffering from. Now, this is key for substance abuse counselors, is that we do not make these determinations. I do not diagnose someone as schizophrenic or as bipolar or something. But when I recognize the symptoms and there's not a primary diagnosis, or there hasn't been a diagnosis before, I may send someone off to see a psychiatrist or something along those lines, or a doctor, therapist, who is qualified to make these diagnoses, and then they do that. Mine is a diagnostic impression. Now, the medical model, there's a lot of objections to using the medical model, and a lot of objections to the idea of the medical model as a solid basis for diagnosing mental disorders. There are a few issues with that. One of them is that we understand symptoms. If someone's psychotic, I can say, well, look here's Joe Blow, and he's psychotic because he's exhibiting this, and this. And he could be having a schizophrenic episode, or he could be tripping on some really good acid. I don't know. But depending on what's going on with the individual, the cures may be out of reach. People who have schizophrenia are not likely to be cured. They're just not. They can be given medication, and that will manage symptoms for them. People who are bipolar, with what we have going for us today, are not going to be cured. They will be, they can have their symptoms managed with medication. And of course, people who have all of these conditions may also benefit from being in support groups and counseling, that kind of thing, can benefit from the talking cure. If you have other illnesses like cold, cancer, flu, TB, syphilis, you have symptoms, but blood can be drawn, and we can do lab tests. We can run those and culture bacteria and check viral loads, and then we can confirm certain diagnoses. And with most illnesses that we have going on, there's treatment for it. And some treatments are better than other treatments, and there are illnesses that we manage symptomologies that we can't cure or treat. Colds, for instance, there is nothing out there to cure a cold. Nothing, as in no thing. You take aspirins, you take other things, you rest, keep warm, drink plenty of liquids, that kind of thing, and you let it run its course, because this particular virus, this cold virus, is not something that we have a cure for or a vaccine for. Flus we have a vaccine for, and they either protect us from catching the flu virus, or they ameliorate the severity of the flu if we get it. So, but cure it? No, it doesn't. It's something you just have to let it run its course and hope you get through it. There are other issues as well, and that doesn't work with mental health issues, by the way. People can have stress-related illnesses, for instance, some PTSDs and things, which may be cured over time, which, then may work out. And we have issues that we bring forward with us in terms of adjustment disorders and things like that, that we can talk about in terms of curing, but that's usually with the talking cure, and maybe assisted with medical interventions. Another issue that's involved with diagnosing people as mentally ill is people who define it usually haven't had it or don't have it. Often is the case, and you'll find this with discussing things with mentally ill people, their illness is not as big a concern for them, their symptoms are not as big a concern for them as they may be for me or some other professional. The way they behave that may make them socially unacceptable to a lot of people isn't as big a deal to them as it is to people who are not like them or people who may be judging them. In theories, we've already looked at some of the movers and shakers who came up with these various approaches to treatment, who don't believe that diagnosis is particularly important when you're dealing with individuals like this. But if you're an adherent to the medical model, then the diagnosis is critical because you have to have it. Many, if not most, mental emotional diagnosis patients have been misdiagnosed at some point in their lives. I don't know if I probably haven't showed you guys the Nothing Wrong with Me, a student film that my students did a long time ago, about 15 years ago. But there was a little girl in it, Nikaya, who had been diagnosed as ADHD and then as bipolar and eventually as schizophrenic. As she got older and her conditions worsened, her diagnosis was, they upped the ante on her diagnosis and on her treatment as well. And that's not an uncommon experience for people who have mental disorders who've been diagnosed. So misdiagnosed illness, as often as not, is mistreated illness because a number of the approaches, and particularly the pharmaceutical interventions that are used for these various diagnoses, are different, and one does not necessarily work as well with one diagnosis as it does with another. Classification of mental disorders per DSM-5. Generally speaking, and this is in general, the conditions that we see the most are anxiety disorders, thought disorders, mood disorders, and personality disorders. And you'd think probably that the anxiety disorders, being a milder form of mental illness, would be the most represented in the substance abuse ranks, but it's really not. The ones that we see the most numerically, statistically, is mood disorders, bipolarity, and in particular bipolar disease. And we see all of the rest of this. And we see, again, if you see someone who has a bipolar disorder or someone who has a SUD, they're going to have symptomologies of anxiety disorders, but that may not be what they're having. So some of these diseases kind of bleed over into one another. And the classifications are done in a way that helps us think categorically about this illness, but sometimes we run into about these illnesses, but sometimes we run into people who defy neat classification, who defy neat categorizations into these states. Anxiety disorders used to be called neurosis. Dr. Freud came up with that. And you find things like phobias, complete with panic attacks, that kind of thing, PTSD, obsessive compulsive disorders, all fall into under the heading, a general heading of anxiety disorders. And these are usually treated with counseling and with medication, and the medication being largely benzodiazepines. Prescribed at anxiolytic doses, anti-anxiety agents. Thought disorders, psychoses, psychotic breaks. You can have psychotic events with a whole bunch of conditions. If you're on a speed run and you're up for 5 days and haven't slept and you pushed your body as far as you can push it, you may start hearing things that other people don't hear, seeing things other people don't see, feeling coke bugs crawling around under your skin. And the symptomologies that I'm seeing there, I know is associated with the end of a heavy speed run or coke run. But there are also the symptomologies that you would find with a psychosis, with people who are hearing voices or who are hallucinating or who have delusional fantasies, those types of things. Then you have the mood disorders. Mood disorders are the most common of the disorders. And depression, just unipolar depression, has been referred to many times as the common cold of mood disorders and the common cold of mental illnesses because it's so prevalent. And a thing that we need to remember about this time too, when we're thinking about classifying mental disorders, is that everybody has anxiety. Anxiety is normal. It's only when it becomes crippling, when it is clearly interfering in an individual's life, that we think about it as a disease. But you and I have anxiety all the time, you know. I'm supposed to be at a meeting at 4 and damn this traffic. You know, there's no way I'm going to make it. Creates anxiety in me. I hate being late for meetings and things like that, you know. Anxiety, going to the doctor. I've got this tightness in my chest. I'm coughing. I'm running a fever. It must be COVID, right? And I get there and find out it's just a respiratory infection. I'm negative for the virus. Anxiety tends to go away. Mood disorders. Everyone gets depressed. Everyone gets depressed. And we have natural ups and downs in our lives all over the place, right? Win the lottery, you're up. Woo-ha! Kind of manic there. Government man comes by and takes 2/3 of your lottery winnings for taxes, you're down. That kind of deal. So mood disorders are natural too, but when mood disorders become pervasive, when you are crippled by them, when you can't get up out of bed and take a bath, shave your face, go to work, whatever, now you're looking at something a little more serious. Personality disorders. And there are a number of them. Antisocial personality disorders, sociopathic personality disorders, dependent personality disorders. They're fairly common also. Personality disorders are something that doesn't really go away. They can get better, you can treat them, they can be medicated, you can work with people in counseling and stuff to make them better, but they don't necessarily go away. I got ahead of myself looking at this slide. Yeah, everyone has it. Normal anxiety is different from anxiety disorder. And the thing that makes it most different is the symptoms of anxiety disorder interfere with normal functioning. And they include general phobias, just being afraid of stuff. Even phobophobia, that's fear of being afraid. Agoraphobia, fear of going to the marketplace. Triskaidekaphobia, fear of 13s. And phobias are problematic if they are unreasonable phobias. It's not phobic for me to fear walking across Highway 225 at 4 o'clock in the afternoon when all the plants are getting out, because it's a good way to die if you're trying to do that. But it is abnormal phobia if I'm afraid to get out from under the street light at the end of my driveway at night, because if I get out of that circle of light, there won't be any air to breathe and I'll suffocate. And every time I get near the edge, I start experiencing this tightness, this panic. I freak out and I run back to the center of the light, things like that. Is that an anxiety disorder, by the way? I'm experiencing anxiety, but that's probably not the problem. There's some delusional stuff going on there, and there may be schizophrenia. So if I'm just looking at what the patient is experiencing in terms of the anxiety, I may miss that. Post-traumatic stress disorders, PTSD, obsessive compulsive disorders, OCD, and panic attacks, gastrointestinal problems, loss of sleep, inability to concentrate, all of that stuff is part and parcel of anxiety disorders. And we'll have people there in treatment with us on our patient loads and things like that who suffer from this. They are usually treated and managed medicinally. People take things like Xanax and Transine and Valium and Librium and stuff like that so that they don't experience anxiety symptomologies. And you can do this in combination with the talk and cure counseling and that sort of thing. Psychosis. This is Vincent van Gogh. They call him Van Gogh, but if you're in Holland, it's probably Van Gogh. Psychosis refers to a major disturbance of normal intellectual and social functioning, where you lose contact with reality. I knew a therapist one time, by the way, whose phone talked to her. Not someone on the phone. Her phone itself talked to her and told her things that only she knew, that no one else knew, got it from the phone. Schizophrenic people have interesting ways of organizing their world, and sometimes they have their own language. They get messages from places we don't get messages from. One of my schizophrenic clients, very early in my career, by the way, was a Navy veteran who'd been mustered out of the Navy for, I think it was what they called, Section 8. Got him out for, it was a psychiatric discharge, but it was honorable circumstances. I mean, he tried to be a good sailor, but his mental capacity wouldn't allow him. His mental capacities, his illnesses, his symptoms. In any case, and I think I may have shared this with y'all before, but he's the one that went down to the wheelhouse in Deer Park and tried to overthrow the regime there. And he went there armed because God told him to overthrow the wheelhouse. And when he did, when he went down there, they kind of punched him around, took his gun away from him, kicked him out. He wound up in my office with his girlfriend, and he was telling me that he was doing what God required of him, so I asked him, how did God tell you what he wanted you to do? Did you, get a visit from an angel? Did he talk to you in your head? How'd you get this message? And he told me that the wires in his stomach coiled up very tight, and then when they reached a certain, tension, they released, and the wire fired out the top of his head, and the leather flags told him what to do. That also sounds like old Navy Signal Corps stuff when they sent messages by flags running up the mast on a line. But anyway, what do you do with that? Don't drink, read the big book, call your sponsor, go to meetings. Because he was a veteran, I was able to get him into the VA, and he spent about a month on a psych ward, and he got his medications adjusted and things like that, and he was stabilized and came back out. Psychosis is generally associated with drug use, people who are tripping or have done too much, or even alcoholics who are in the grips of delirium tremens or having hallucinations and things like that. And if that's the case, if it's drug-related, then after a short period of time, if you can keep the client alive, which is if he's an alcoholic. Not so big a problem if he's doing acid. And get him further and further away from that drug use incident, then you should see an alleviation of the psychotic symptomologies. But there are people who have these type of symptomologies who are not fooling around with drugs. They are not drug related. And some psychoses have an organic cause. And those are called functional or organic disorders, rather, because we know what caused them. If others that we don't understand the cause of are functional disorders, and they don't have a known or obvious physical cause. And schizophrenia and schizoaffective disorders are like that. We're not sure exactly why people are schizophrenic. They just are. Schizophrenia, by the way, means shattered mind, and psychosis is associated with that disorder, although psychosis is not solely associated with that disorder, so that if you see someone who's having a psychotic break or who is being psychotic, they are not necessarily schizophrenic. Schizophrenia also does not mean split or multiple personalities, and this is something that you hear a lot, even today. I mean, and not as much as it used to be, but people say, well, you know, I think he's schizophrenic. The guy's got a split personality. You don't know who he's going to be. And that's not necessarily schizophrenia. Schizophrenics can have their symptoms managed medicinally. There's medication that they can take, and we'll talk about that in a minute. But they can also self-medicate. And very often when you're dealing with clients that have symptomologies, if they want the symptomologies treated at all, they often may prefer to do it with themselves. Schizophrenics, for whatever reason, like to smoke weed. And I don't know if that's, a function of the schizophrenia, that they want to smoke weed, or if the weed smoking may cause you to be a tad schizophrenic. Who knows? Medications that are used to treat thought disorders are antipsychotics. They're sometimes referred to as major tranquilizers, although that's a bit of an antiquated term, although they still may be, a major tranquilizer. But and they're also referred to as neuroleptics. They're normalize the system to where you're not delusional or hallucinatory, and you may be doing some like grossly inappropriate things behaviorally, and that kind of is downplayed too. In the 50s, the drug of choice for people who have psychosis, for psychotic patients, was our old friend paraldehyde. Remember bleach lightning? That you go into the detox unit, go into the drying out farm, and pour a lot of that down the alcoholic, and next thing you know, they're good to go. But paraldehyde is a sedative, and it's a good one. It's a fairly safe one. It's got a wide safety margin, but it's not real good for managing symptoms and letting people out of the hospital where they can take these medications and go on their merry way. And, it's something that you use for acute circumstances. One of the So the classification of drugs that came along are the tricyclics. These are sedatives were replaced largely by the phenothiazines, and these are tranquilizing drugs with antipsychotic actions, and they're called tricyclics not because they circulate 3 times or because they have 3 types of effects. They're called tricyclics because they're based on they're either derived from Semisynthetic analogs of are synthesized on the basis of the three-ring molecular structure of the phenothiazine molecule. And so they've got that basic three-ring structure with a bunch of additives to it that make them do other things. And so these tranquilizing drugs with antipsychotic actions work very well to stabilize someone who's psychotic and having a psychotic break. Chlorpromazine was one of the first of these drugs to be widely utilized. It goes by a number of names. Probably the most familiar to us is Thorazine. If you're being delusional, hallucinating, maybe being combative, whatever, when you wind up in the hospital on Monday, they stick a syringe full of Thorazine in your butt, and next thing you know it's Thursday, and you don't know where the rest of the week has gone, or where you are, or why you're there. Kind of turns you into furniture and makes it easier to deal with you. But the psychotic symptomologies go away. That's in an acute situation, but chlorpromazine is also prescribed and used with people who, for instance, have a diagnosis of schizophrenia to keep them normal on a daily basis. And you'll see it used in combinations with other drugs like haloperidol, etc. And it may be combined with other drugs that you see utilized for instance, anxiolytic drugs, and also antidepressant drugs and anticonvulsant drugs that may all be used to treat someone who has a diagnosis of schizophrenia. Once upon a time, if they're, what did you do with people who were schizophrenic, who were hallucinating, who were having psychotic episodes? Saint Bernadette of Lourdes saw the Blessed Virgin, and the Blessed Virgin gave her messages, and only she could see the Virgin, and she conveyed the messages from Mother Mary to the crowds. And the spring at Lourdes had healing qualities, and miracles happened there. And Saint Bernadette interpreted all of these things for the people. Saint Bernadette, and I'm not taking on the church or anything else, may well have been a saint. The things that Saint Bernadette was talking about and doing are also things you could expect a schizophrenic to do. And I guess maybe if you're working with schizophrenics, you ought to make sure they're not saints before you get too far involved. If someone's talking to God, make sure they're not before you go any further. But, if people have delusions and hallucinations and they're untreated and you can't do anything with them, sometimes they become a danger to themselves, much more a danger to themselves than to other people. There was a guy who was obsessed with a tiger in a zoo in Asia. Oh my goodness, it was about 2-3 years ago. And it was a video of it. It's horrible, by the way. And the tiger killed him. He got in the enclosure with it because he thought, that he was communicating with the tiger, that they had a bond of some kind. And apparently the bond was the same bond that, you might have with a Big Mac. But at least as far as the tiger was concerned. So, delusions, that sort of thing, can get people in trouble. We think that they're possessed. We try to beat the devil out of them. That term came from somewhere. If you make the body uncomfortable enough, the demons will leave it. We trephine them, drill holes in their skull to let the evil spirits out. If they're too far gone, we'll tie them to a stake and burn them. We'll put them in chairs and spin them for hours. We'll tie them to a chair and dunk them in ice water you know, all of these things to cure people, and it didn't. And in lieu of curing them, if you had nothing better to do on a Sunday afternoon in London, you could go to Bedlam Hospital, and for a penny you could tour the lunatic asylum and see all the crazy people chained to the walls. It was kind of brutal. Anyway, societies have to deal with individuals, and there is no society that I'm aware of anywhere on earth ever in human history that was exempt from these types of things popping up among them. How they deal with it is how they deal with it. Mood disorders. These are illnesses where you have depressed and or manic symptoms. You can have depression without mania, you can have mania without depression. Either way is a mood disorder if you have them and they're profound and or significant enough to interfere with your normal functioning, the way you live, that sort of thing. If you're abnormally depressed or abnormally manic, you can have a diagnosis tossed your way. Unipolar depression is different than bipolarity. Bipolar disease has both a manic and a depressive state. Unipolar depression is just depression. When that depression is alleviated, you know, you may have a lighter mood, but it doesn't really approach mania. Mania is something else. It's like being high without doing drugs. Depression can be thought of in a couple of ways. Just like we talked about organic and functional schizophrenia. Again, depression being the common cold of the mental illnesses, everyone gets depressed. Half the country's depressed over the election right now. You know that, right? Other half of the country is not quite manic, but not as depressed, maybe. So the things happen. And if I come up to someone who's wearing their Make America Great Again hat and say, buddy, you look a little bit down, and he can just point to the hat, and I know why he's down, you know. That's an exogenous depression. He had something going on for him, and he wanted it to work out a certain way. It didn't work out that way, and now he's down in the mouth. You know, my wife left me. I'm depressed. My team lost. I'm depressed. I got released from my job. I'm depressed, you know. I backed over my favorite kitty cat on the way to the grocery store. I'm depressed. And so that when you see me and I'm depressed, I can point to that, and I can say that's why. And that's exogenous. There is a thing outside me that I can point to that has disappointed me, upset me, made me sad, whatever, and now I have depression. Funny thing about those types of depressions, time tends to alleviate or to cure them. I think more in terms of alleviation, because I can think back, you know, I can dredge that stuff back up again. I've got a pretty good memory, and depress myself with something that happened a long time ago. I can remember it, bring it into my consciousness with enough force to create that sadness in myself again. Some of us are very good at doing that, but it's still an exogenous depression. And when you ask me, why are you sad? I say, I'm thinking about someone. You know, I lost someone. That's why I'm sad. That's why I'm thinking about it. You know, or I missed an opportunity. I've always regretted that I didn't take this chance or make that move or whatever. That's life, kiddos. Nobody gets through it without having some of those types of experiences anyway. But then there's the endogenous type of depression. And that's kind of like that functional psychosis. We don't really know exactly where it comes from. It's just there. And again, we can hypothesize that most likely this is a chemical imbalance thing that's going on that creates an endogenous depression. But my endogenous depression manifests itself irregardless of, or irrespective, rather. I just said that, didn't I? Irregardless. I always tell people don't say that. It means regardless of regardless. Irrespective of what's going on around me. And if I have this type of endogenous depression, I bet some of you can relate, it does no good for people to come up and tell me, hey, cheer up, H, you know? Look, you got it made, dude. You got a good job security, make a nice living, you get to work in your garage, you don't have to go punch a time clock. You've got a nice wife. You've got a nice house. Everything's cool. And I know all that. I know all of that, and I know I have it pretty good. And I know that I should be grateful for the things that I have, and I know, that I've got it much better than a whole lot of people in the world. I wonder what I'm going to have for lunch today, not if I'm going to eat today. I'm aware of all that, but I still am so down. I still am so sad. I still am so blue that I could jump off of the bridge, And you telling me to cheer up doesn't help. And when someone comes up and points out to me that, I should be grateful, I get it, but it doesn't help. And when someone tells me, I was sad because I had no shoes till I met a man who had no feet, I kind of casually want to strangle him, but I don't have the energy. That's an endogenous depression. Where'd it come from? I don't know. How do you make it go away? I don't know. I have an answer. It's better living through chemistry. In another class, I showed you a little cartoon, or at least I talked about the cartoon, where when I'm having these types of situations going on with me, I go to the psychiatrist and he says, here, take these drugs and you'll feel better in 6 weeks. And I can go to the psychotherapist and they say, come on into my group and work with us here and we'll get those issues resolved and you feel better in 6 months. Or I can just go into the house and pour myself a stiff drink and I'll feel better in 6 minutes. Self-medication is an issue, and times of relief are an issue in these types of disorders as well. Mood disorders, depressions, and bipolarities, by the way, these are the people who are the highest suicide risk among all of your clientele. And people who have depressive disorders, if they decide to kill themselves, for instance, will probably do some drinking before they do it. And that's not because they're alcoholic or substance use disorder. It's just because that's what people tend to do when they're suicidal, to either medicate the fear of the unknown or to give themselves a shot of courage, they used to call it, to take that big step. But you see a lot of depressed people and a lot of bipolar people in treatment. They're very common there, and you have to assess for suicidality because this is the group that's most likely to do it. I'll talk about that again in a minute. Bipolar disorder. This is the depression combined with the mania. This disorder is it is the most representative of the comorbidities associated with substance use disorders. We see more bipolar people in there than any of the others. And the SUD, substance abuse dependency comorbidity with bipolar disease is around 60%. So that's like 6 out of 10 patients that you see are among who have a dual diagnosis is not 60% of the overall patient load, but those who have a comorbidity, 60% of them will be bipolar. Bipolarity is where you have the depression, which is an endogenous depression that's probably related to chemical imbalances, chemical changes, or abnormalities that occur in the individual. And that's coupled with their substance use disorder. And that substance use disorder may be any drug. Schizophrenics kind of lean towards weed, but they may be drinkers. People who are depressed, oddly enough, will want to drink, which is a depressant, or they may do some other drug. Bipolar people, by the way, are the ones most likely to have a serious nicotine habit and treatment, and have a real tough time getting off the nicotine, because they have a dopamine deficiency, it seems like, going on, that the tobacco, the nicotine, kicks into high gear for them. So they get a good deal of relief from being a cigarette smoker. Anyway, people who have dual diagnosis with SUDs and bipolar disease have a poorer prognosis for recovery from either one of the illnesses, and more severe symptoms than do people with bipolar disease without a SUD, and vice versa, people with an SUD and without a bipolarity. Bipolar disorder is cyclical. You'll hear people who have bipolar disease talking about their cycles, how quickly they cycle through from depression to semi-normalcy to mania, etc. Other comorbidities that occur with bipolar disorder include obsessive compulsive disorders, eating disorders, cardiovascular abnormalities and problems there, tendency towards sleep apnea, and these comorbidities are also common in substance use disordered people with no bipolar diagnosis. So seeing the OCDs, and you'll also see anxiety disorders coupled with this too. There are two types of bipolarities. Both of them are treated medically with a medicine regime, and both of them are treated to some extent with the talking cure. Bipolar 1 is the most serious form of the illness, has the most virulent symptoms. I feel like I may have jumped over something that I needed to say with all of these, but when I get to bipolarity, I've had a lot more experience with bipolar clients than I have with some of the others. As no one who has one of these diagnoses, whether it's bipolarity, schizophrenia, anxiety disorder, personality disorders, sociopaths did not ask to have a sociopathic personality disorder. And they may do rotten things to people, and they may not have a conscience, and they may, and may seem like, really, really terrible people, maybe even monsters. But if they're sociopathic, they didn't ask for that. Bipolar people did not ask for their symptoms. Schizophrenic people did not ask for their symptoms, and they didn't choose them, and they don't get a vote in whether they have them or not. So they're going to play into it. Imagine how hard it will be to take a medication for symptoms that keep telling you you don't need the medication. When bipolar people who's going through their cycle, when they're getting into their mania, can be supremely arrogant and terrifically tough to deal with in that regard. I've had plenty of people tell me, you don't know. You don't know what it's like to be me. You don't understand. You don't have the answers. You're not as smart as you think you are. All of that stuff. I'm not a sick person. I've got this. I've got a handle on this. I know what I'm doing, baby. That kind of thing. And when I think of this, I think of my younger brother James, who died a little under 2 years ago. I've been to those AA meetings that you go to. Boy, those people got it wrong. They don't know what the hell they're talking about. A bunch of losers and shit. Says the man who hasn't had a job in years, who's got kids all over the place by all kinds of different women. None of them live with him, this kind of thing. Those people don't know what they're talking about. And it does me no good as a counselor, as a brother, or as anything to point out to him, they're sober and you're not. They're getting on with their lives and you're not. They're making it and you're not, because it does not compute. He can't hear things that way. His symptoms are telling him he doesn't need what we have to offer. And as a family member, if you've ever dealt with someone like this, you know how frustrating that is. As a counselor, you have to be in a place where you can recognize that this isn't something personal. This isn't something that someone is doing to reject you or what you have to offer. It's a sick person whose disease is telling them, you don't need this. Off my soapbox now. Bipolar 2 can be awfully disruptive as well, although symptomologies with bipolar 2 are not as virulent as with bipolar 1, and it's not as pronounced. It may not be as obvious to people. It may not even be diagnosed. People get through their lives with bipolar 2 without really ever being diagnosed or taking any kind of medicine or getting any kind of treatment for it. Bipolar 2 features as hypomania rather than hypermania. Hypermania is bouncing off of every wall. Hypomania is only bouncing off of 2 of them. Hypomania doesn't mean no mania. It means a lower form of mania. The mania is not as intense. The cycle may be different than you'll see with bipolar 1. And when people are manic, whether it's hypomanic or hypermanic, they still have an inflated sense of self. They're very confident and competent. They overjudge their own worth and capabilities and things like that. And consequently, they get in trouble. They do risky things. They take financial risks. They become sexually adventuresome and have consequences to pay behind that. And all kinds of strange things can happen with that. Again, it's not someone's fault that this is going on, even when it comes time to take the medication. And medication compliance is always a challenge when working with someone who's dual diagnosed. And of course, with bipolar disorder, most of them are treated with medication combined with counseling. And trauma is found across the spectrum of dual diagnosis and across the spectrum of substance use disorder. So note that. And trauma-informed technique should be used with these clients. Go into it expecting that there's going to be some type of trauma there. If there's not, fine, it's going to be a pleasant surprise. I learned a long time ago in working with female clients when I was young in the profession, and had a lot of women were seeking treatment as outpatients. Women are more likely to say something's wrong with me. I need to go and see someone than men are. But just kind of rule of thumb, if I said that 3 out of every 4 women I see this week are going to have a history of sexual or physical abuse of some kind in their background, bingo. That's pretty right on. And I haven't seen a lot to change my feelings about that particular statistic over time. But the lifestyles of an addict also carries, or of a substance abuser, carries with it risks. We're victimized every bit as much as we victimize, probably more. Same is true with mental health patients. People are afraid of them. They think that, these are violent people, they will hurt you and stuff like that. Most mentally ill people are victimized at a much greater rate than they victimize other people. Folks take advantage of them. Folks hurt them because they can. Nearly all co-occurring disorders carry an increased risk for suicide, and it should be constantly monitored by their treatment providers and assessed and for risks of self-harm. Bipolar and unipolar depressions, bipolar disease and unipolar depression, do not respond to the same treatment regimens, even though some of the same drugs may be used. For instance, lithium doesn't do anything. And lithium's an element, it's a naturally occurring body salt. It'll help balance the mood swings in someone with bipolarity, but it won't do anything it will make matters worse with people who are unipolar. So you have a different way of treating the illnesses. If someone is majorly depressive, and this is a profound case of depression that's been ongoing and hasn't responded to other treatment, electroconvulsive therapy may be employed. Once upon a time, this was a fairly brutal therapy. They strapped you to a table, put a leather chew toy in your mouth, and applied voltage to your brain while you were awake. And it shocked the brain, and it changed the brain chemistry, and it caused dopamine to be released in greater amounts, and the mood elevated. It worked. It still works. Of course, nowadays, they may still put the leather tether in your mouth so you won't bite on your tongue and lips and things like that, because your body will probably respond to the electricity. It's not necessarily, though. But they anesthetize you before they throw the electricity to you. And it does. It elevates the mood. People come out of it, with improved conditions. But it's not the most advised or first option with people. Major depression, they treat you with SSRIs. SSRIs is selective serotonin reuptake inhibitors. And these are things like Prozac and Paxil. And they also give you anxiolytics. You may be taking Xanax or Valium with that. And antipsychotics, chlorpromazine or haloperidol or something along those lines, sertraline, which is Zoloft. Bipolar disease is treated with serotonin and norepinephrine reuptake inhibitor, SNRIs. Also SSRIs, the selective serotonin reuptake inhibitors. The tricyclic antidepressants that we talked about a while ago, the phenothiazines, and the monoamine oxidase inhibitors, MAOIs, that anxiolytics, and with also anxiolytics, usually benzodiazepines. So it's common to find people who are taking sort of a cocktail of all of these drugs, and to medicate or not to medicate. Let me go back here for a minute, though. when you're make an observation. If all of us who are watching this, who are listening to it, went to the doctor with the same type of conditions, the same type of symptoms, the doctors may prescribe to us any of these medications in various amounts, in various combinations, and things like that. And for patient one, over here in the classroom, a combination of an MAO inhibitor and benzodiazepines and, I don't know, something else. The combination may work for patient A, but it won't work for patient B, and it won't work for patient C, and it will work for patient D, but it won't work for patient E. And the doctors, depending on your reports back of how your symptoms are coming along, will adjust and switch medications. And this can be crazy making for someone who's going through this, because, I'm an experiment. The doctor is trying to hit on the right formula of medications that's just right for me, and the right amount of medications that's just right for me. And here's where that problem comes in again with lag time. If I come in and I start taking medication to treat my bipolar disorder, to treat my schizophrenia, to treat my unipolar depression, to treat my personality disorder, whatever's going on, there's a lag time between when I start taking the medication and when the medication works. I have to take it for weeks sometimes before I'm able to apprehend any benefits. And because this is a kind of a drawn-out process that takes a little while to get there, I may not even notice that I'm getting better. And so you'll have a client, who may be in there telling you, I went to see that doctor you sent me to, and he put me on this sertraline and stuff, but I can't see a damn bit of improvement here. This sucks. I'm not getting any better. I'm just same as I ever was. But right behind him, all the family members are shaking their heads and saying, no, don't take him on. He is better. We see it. We see the change. He doesn't necessarily see the change. So that's a piece of it too. To medicate or not to medicate. Taking medication for these types of disorders controls symptoms. And for some people, that allows a great deal more freedom. Because there are folks out there now who are, sometimes they are living in like community homes or halfway houses or things like that, which I think is a real good thing, because here, in the best of all possible republics, in the greatest of states in that republic, we handle our mentally ill people primarily by putting their asses in jail. So that's where people with bipolarity and schizophrenia and things like that wind up. We put them in, we incarcerate them. And we may treat them while they're in there. We may manage the symptoms, but then we let them out, and then they stop doing what they're supposed to do, and then they start doing what they were doing before they got picked up, arrested, or treated, and whatever. And it becomes a cycle. In and out, and in and out, and in and out. There's a good film. You might can pick it up on Amazon or Showtime, I don't know. Or I may post it for you for an extra credit thing. It's called The Release, The Cycle of Incarceration with the Mentally Ill. The delusions don't go away because they put you in jail. And incarcerating people for mental illness makes no more sense than incarcerating people for chemical dependency or for alcoholism. Being jailed doesn't fix it. It's like incarcerating someone who has tuberculosis for coughing. If you have TB, you're going to cough, and it doesn't matter how many years they put you in jail if you have TB. TB, you're going to cough. Anyway, we've got to look forward with this, with healthcare reform and things, which is, it's happening. It doesn't matter if you're a Republican or Democrat or what you think about it. It's happening. It's got to. It must. That will go on. Medication controls symptoms, allows people more freedom to be employed, allows more people to be part of a family, allows more people to live on their own independently than it used to. But we have suffered a little bit from the loss of the genteel asylum, where people could go and have a pretty nice life, with people who care about them and take care of them. They have a certain element of freedom to be able to come and go, but they have a safe place to be too, because with people who are dual diagnosed, or people who are just diagnosed with a mental disorder, even if they don't have a substance use component, the world's a dangerous place for them. It's a dangerous place for them, and a nice, safe place is good. These drugs have a lag time from where it's first taken to observable experiential benefits. There is also a situation where individuals have unpleasant side effects, that some of these medications that they take are some of the medications that they take may cause problems, like tardive dyskinesia or something along those lines. Lecture. Working. Thank you.
Have a good day.
You too. Just got a package, guys. They have unpleasant side effects, and people don't want to take them because they make them sick. You have to, some of these medications can be pretty toxic, so that you're taking medications for this, that, and the other, and you have to have blood counts to make sure that your liver's functioning right, and that kind of thing. Patients also have reservations because they don't like to be dependent upon medications. I don't want to be drug dependent, particularly if I'm here to recover from a drug dependency. I come in here to get off of these street drugs that I'm doing and stop all the drinking that I'm doing, and now you tell me, because I've been acting a little crazy without my drugs, that I need to be on this other stuff, that I need to be on antidepressants, that I need to be on mood elevators, that I need to be on antipsychotics, that I need to be on anxiolytics. And you know what? I don't like that idea. You know what I'd rather do? I'd rather go out and self-medicate and take the drugs that I want to take to make me feel better or to act better. You should see those old old commercials about stop the madness, get sober. Hell, I'm getting high to stop the madness, thank you very much. Anyway, it's a real challenge to work with people who are dual diagnosed and manage those cases, because mental health diagnosis is common among those who have substance use disorders, and the most common, of course, is the bipolar diseases. But those with dual diagnosis present specific challenges if you're a treatment professional in terms of assessment and treatment planning. Depending on what the other diagnosis is going to inform how you create a treatment plan for your clients, how you work with them, how you assess what's going on with them, how you assess the severity of the conditions and what to do about it, and what constitutes success, and how can you best support them in getting there. Medication also helps people to manage symptoms and to live more normal lives. And assuring that people stay on their medication has always been a challenge in the treatment with this specific population. Substance abuse professionals need to know about the types of conditions substance abuse, certain substances are prescribed to treat. Sometimes you'll see people who come into treatment and who won't be able to tell you, yeah, I'm seeing a psychiatrist. Well, what are you seeing him for? Well, I'm not sure, but he's giving me sertraline and Xanax, So know a little bit about what sertraline and Xanax is going to be prescribed for. And if you do that, then You'll also be able to talk with your clients a little bit about their medications because it's of concern to them. Gone, I hope, are the days when if you ask your doctor, well, what is this? I don't know if I want to take this. What's it going to do? What's it going to be like? And the doctor looks back at you and says, where did you study medicine? I'm the doctor, and you have this condition, and this is going to make you better. Take the damn medicine. And I hope those days are gone. The truth of the matter is, you're going to have to discuss with your clients. If they're taking these medications, you're probably going to have to discuss the medications with them. And it's a good idea to know a little bit about what you're talking about. And if you don't try to fake it. If you don't, you tell people, you can certainly tell people, I don't know what that drug is. I'm not familiar with that one. Let's look it up and we'll see if we can't figure it out. Don't try to bluff your way through with people that are needing good information. One of the and don't tell people, don't discount their concerns, and don't tell them they don't need to take the drug. That's very important. If a client is concerned about taking this drug, I will recommend that they talk to this doctor, or if they want a diagnosis to someone else, want a referral to someone else, I'll make them a referral to someone else that they can talk to. Discussing your medication, what it does, why I'm taking it, how long I have to take it, what are the side effects, will it hurt me, what if I do this, what if I'm like that. That's taking care of yourself, man. When you're talking to people about this, that's taking care of yourself. And so the professional, whoever that professional is that's insisting you take the medicine or is prescribing for you, should listen to and address your concerns. It's not for someone who, like you and I, who don't have a medical background. For the most part, we're not doctors. I don't think I have any physicians in class. I may, but we don't make these. We don't make these kind of things and say you don't need to be taking that. Just throw it away. And I've seen that happen. And I hope that professional counselors have gotten away from that. And even AA and NA sponsors. Some of them haven't, though. Some of them will still tell you, you don't need that. All you need is God and the big book and your sponsor, me, and we'll get you through this. That's not necessarily true. And some of these medications, depending on the medications, may be dangerous to just stop. You have risks of withdrawals and things like that, or with a reoccurrence of symptoms in a more pronounced way. That said, most of the drugs that we prescribe to treat mental disorders are not particularly addictive and can be used somewhat safely. But again, some of them cause some unpleasant side effects, and some of them have some toxic effects. One of the challenges of case management with dual diagnosed clients is ensuring compliance with a medication regime. There's my little brother, again, I'm referencing him, but I've seen lots of lots of people. My little brother is compliant if you're there to make him compliant. I could say, hey, Mike, let's go to an AA meeting, and he'd say, give me a minute, let me get my cigarettes, and away we'd go. But if the AA meeting was right across the street from his house, and I'm expecting him to walk across the street and go on his own, it ain't happening. When I've got the medication and I've delivered the medication to him, and he's got it right there, and he's got it in this little, daily organizer, which he liked to play with. I've never met any drug addicts who didn't like to play with medication. He'd take it, and because it didn't give him a high, he'd usually take it the way it was supposed to be taken. But if he ran out of medication, that was that. He wouldn't walk across the street to get it filled at the pharmacy unless it was a narcotic, or had some other kind of nice buzz with it. So clients, there are a lot of reasons they don't want to take their medications. Unpleasant side effects or it doesn't get them high or whatever. Dual diagnosis also presents an increased risk of relapse for these, an increased risk of relapse for these people who have two or more diagnoses going on. And some dual diagnosed people, their risk of relapse is associated to their tendency to want to self-medicate, to take something that they like better than. Well, I lost my train of thought. But some dual diagnosed individuals prefer to self-medicate. I'd rather smoke weed and drink whiskey than take those pills you gave me. That makes a little better sense, doesn't it? And we reached another exciting conclusion of Howard's Garage. I think I may have, I may post a video for you in here too on the video I talked about, Nothing Wrong With Me, student production. I've posted it in several classes, and if you've seen it before, you don't have to worry with it, but I'll put it in there anyway for you to look at. And with that, I'm through if you are, and I bet you are. So I'll see you in the next lecture, and we'll have some more fun. Bye.